And I'll move on to Dr. Najafian, who's going to open up our Nephrology Path conference.
I could start it up if you want. I think we're all happy to begin a new year and welcome the new fellows. And we're going to go through these conferences with you about roughly once a month. And what we do is present interesting cases. We have been asked to sort of start it off slow, so this one might have a few slow pitches in it. But what we really like to do is also get participation. So feel free to participate. I've noticed that the security allows people to change their names. So, you know, if you want to rename yourself, give yourself your favorite character, maybe your attending of choice, you can do that. But, you know, put your comments in the chat, ask questions, raise hands. This is meant, you know, to be a learning experience for everyone. And hopefully it stimulates some thought and discussion and maybe some, you know, interesting projects along the way too as we go through the year. I think I can start off with, I'll do the first two cases, and then Dr. Najafian will do the third case. And the first case is one that I believe Neha Deval is going to present the clinical information for. So I have a couple of slides from her. I can share my screen. Okay. And unfortunately, that's and hopefully everyone can see that. Is that correct?
Yes, looks good. You can.
Is it the presentation one or the?
It's in, we see the PowerPoint slide, or the slide and the clips at the thumbnails at the side.
Oh, okay.
So I think at the bottom, if you go to click the presentation, little icon at the bottom.
Let me try that again. Okay. Now I think I'm sharing the right one.
That's great.
Okay. And this is, you're seeing just the presentation mode, correct?
Right. Looks good.
Okay. Okay. I'll let Neha begin.
Yeah, the previous slide.
Yeah.
The first slide. Can you switch to the first slide?
Sorry.
Yeah. Hi, everyone. I'm Neha. I'm a second-year fellow. We are going to discuss a case that we saw in the clinic and who underwent a biopsy subsequently. So this is a 48-year-old woman who was referred by her PCP for AKI, and she had microscopic hematuria and proteinuria. Her past medical history included papillary thyroid cancer, status post thyroidectomy, and she has hypothyroidism now, hyperlipidemia, ulcerative colitis on treatment for that, factor V latent mutation, melanoma in situ. And she was also treated for leukocytoclastic vasculitis in the past. Her medications included Entyvio, 300 milligrams, Synthroid every day, and fluoxetine. When she presented She was having tiredness and lower extremity swelling, but no other symptoms of any dysuria or gross like hematuria or any urinary straining. There was no usage of NSAIDs and no other symptoms of dizziness, visual loss, any rashes, abdominal pain, or any nail issues, and no polyuria or oliguria. Her family history was just included hypertension and diabetes on the maternal side, and there was no history of any kidney disease on the family. Her social history, she quit smoking about 20 years ago and was drinking socially and no recreational drugs. Next slide. Her vitals were stable. Her blood pressure was 140/80 to 90. Her physical examination was unremarkable, except for 1+ lower extremity edema bilaterally. Her basic labs showed a sodium of 134, a potassium of 4.2, chloride of 102. Her BUN was 20, serum creatinine of 1.26, bicarb of 22. Her calcium was 8.1, phosphorus 3.5, albumin was 3.5, hemoglobin was 10.4, and platelets were normal at 400. So no significant abnormalities except for a serum creatinine of 1.26, and her baseline creatinine was around 0.7 to 0.8. Her UA showed a specific gravity of 1.005, 2+ protein, 3+ blood. There were 20+ RBCs, no WBCs. Her UPCR was 5.1 and her UACR was 3.8. We went ahead and got all the serologies which were negative, including like hepatitis B, hepatitis C, HIV. Her complements, C3 was 125, C4 was 37, negative ANA panel, negative ANCA panel. Her kappa was 3.12, lambda was 3.25, SPEP and UPEP were negative for monoclonal component. We also got renal ultrasound that showed normal size with no hydronephrosis bilaterally. And then we went ahead and proceeded with the biopsy, which is going to be on the next slides.
Okay, is there any questions for Nia about the clinical history?
Neha, did you look at her urine? What did the red cells look like?
I actually haven't looked at her urine when she presented at that time. Yeah, we haven't looked at her urine, unfortunately.
So how about differentials? Anyone want to? Okay, we got one person for IgA nephropathy with IBD. Any other considerations?
Just to add, her IBD was super well controlled on the medication. She had no flares or anything in the recent past when she presented.
Did you mention what her baseline creatinine was?
Yeah, it was around 0.8.
There's a question about AKI.
Yeah.
What was the pattern over time they have the creatinine? Was it really an AKI or is it sort of a steady increase or?
I would say it was a kind of a steady increase. It was 0.8, 0.9, went to 1.2 over a couple of months.
And we have another differential of AA amyloid thrown in there. So I think systemic inflammatory disorders driving the secondary amyloidosis. Okay, why don't we, respecting time, move on to the biopsy. Okay. So this is the entire biopsy essentially shown at low power here. And I hope you can appreciate that there's a background of chronic injury. So these areas here, we see a lot of, this is a Jones stain. So we have basically a background H&E stain that also has a silver stain. And the silver stain really helps us see a lot of the basement membranes and matrix. And we see some thickened tubular basement membranes in the interstitium that are indicative of some tubular atrophy. Also increased staining within the interstitium that shows us where there is some areas of fibrosis. And then there's some of these glomeruli that are all black essentially, and they're globally sclerotic glomeruli. So there's a background of chronic injury that's mild, at least mild. And then we also see that there's some of these cells in here that are foam cells. And those are cells, we'll look at them in a little bit higher power, but we see those commonly in kidney biopsies from patients that have had long-standing proteinuria. So they tend to build up in the interstitium in the setting of long-standing proteinuria. And then here are the glomeruli that we can see. And even at low power, we can see that there's a little bit of extra silver staining here in the mesangial stalks that support all the capillary loops. And so we get an idea that there's some mesangial sclerosis here. And we'll look at all of this at higher power. Here's one higher power picture. We're seeing a glomerulus. We see some mesangial sclerosis that I mentioned. And then we see this tubular atrophy and interstitial fibrosis with abundant foam cells, indicating there's probably a history of long-term proteinuria in this patient. Here at higher power, this is a globally sclerotic glomerulus. So when we look at this glomerulus, we can't really find any obvious patent capillary loops. And so we call that global glomerulosclerosis. So the entire glomerulus is sclerotic in this picture. Here's some normal appearing tubules and then some higher magnifications of the foam cells. And you can see that there's these fine reticular silver staining in the cytoplasm that gives it sort of a bubbly or a foamy appearance. And that's where the name comes from. Here's another glomerulus, and we can see that it's more of it's intact. There's more peripheral capillary loops. When we look at the basement membranes, they have a nice thin ribbon-like appearance, but then there's some increased mesangium in areas. And so that it's definitely more prominent. Usually the mesangium is relatively inapparent, maybe a cell or two and then some matrix. And here there's a number of nuclei and abundant matrix in some of these segments. We also see an area where it looks like the glomerular tuft has formed an attachment to Bowman's capsule. And this is an indication that there's been some injury to the glomerular tuft that's resulted in its fusing to a bit of Bowman's capsule here with a little bit of periglomerular fibrosis associated with that. Here's another glomerulus, and this has a more prominent area of segmental scarring. So we see this wedge-like area of matrix that's relatively acellular that's attached now to the glomerular tuft, where we see a prominent expansion of the mesangium and the adjacent portion of the capillary loop, and then some more mild areas of mesangial expansion elsewhere, maybe a little bit of eosinophilic material as well. And then this is a...
Can I ask a question?
Yes.
Hi, this is Justin. I'm one of the first year fellows. What's the definition of an intact capillary loop? Is it that you can see the RBC inside that is just open?
Well, yeah, so this would be normally with an intact capillary loop, you can see a thin ribbon of the glomerular basement membrane, and then there's a well-defined interface between the mesangium and the capillary loop. And so normally we see either just a white space or maybe a red cell or maybe even a leukocyte that's present within the capillary loop. So here's an open capillary loop, a nice thin ribbon. This is probably an endothelial cell nucleus here. There's a few red blood cells, and then there's a fairly discrete interface between the mesangial region and the capillary loop. So when we get to areas like this, where we have a lot of scarring and we can't really even make out the architecture anymore. This is a portion of the glomerular tuft where we're assuming that there were capillary loops there at one time, but now they've been completely destroyed. When we lose this much architecture, we also postulate that there might have been an inflammatory process that led to this level of destruction. And we'll see more of this as we go on. And here's some areas where it's very difficult to see where the capillary loops are. So there could be some evolving obliteration in some of these areas that we're just not able to see. Here's a PAS stain, and this is one that we use for looking at mesangial expansion or mesangial hypercellularity in particular. And we can see these mesangial regions that have numerous cells. So if you look at a peripheral mesangial region, you're supposed to see essentially less than 4 nuclei present. If you have 4 or more nuclei present in these areas, it's considered mesangial hypercellularity, and that's an abnormal finding, and it's also something that's used to help score IgA nephropathy and provide an M score, a mesangial hypercellularity score. We also look to see whether other things are going on. In this instance, we saw mostly chronic injury. We're not seeing a lot of leukocytes in the capillary loops. We're not seeing endocapillary hypercellularity. We're not seeing any necrosis. We're not seeing actual destruction, active destruction of the capillary loops, and we're not seeing cellular crescents. So it's mostly chronic injury so far in this case. And then here's just a higher power picture of the foam cells in the interstitium with an H&E stain. After looking at the light microscopy, we move on to the immunofluorescence microscopy, and here we essentially solidify the diagnosis, and we see that there's abundant IgA present, and it's mostly in a mesangial distribution. And by that, I mean, we're seeing mostly the centrally located staining for IgA that corresponds to the mesangial regions that support the capillary loops. And we're not seeing a lot of staining in the capillary loops, which are more peripheral in the glomerulus here. We see a similar staining for both kappa and lambda light chain, indicating it's a polyclonal process, as we would expect in a garden variety IgA nephropathy. And then we move on to electron microscopy, and we see portions of the electron microscopy that have capillary loops that are relatively normal in appearance, but we do see some alterations in the glomerular basement membrane segmentally. So here there's a little bit of lamellation of the glomerular basement membrane. So, and then here there's an area where there's some thinning of the basement membrane. And again, here it looks a little bit thin, but we do see a lamina densa that's easily made out. There's some effacement of podocyte foot processes here. This is the capillary loop. This is the urinary space in this region. This is the capillary loop here. And we see some intact foot processes in this region. We also see in this area where there's some fusion or effacement of podocyte foot processes, we see these microvilli that are present, and these are extending from the podocytes that overlie this portion of the capillary loop, and this is termed microvillus transformation. So these changes are associated with proteinuria, which this patient has, and so the morphologic changes that we see correlate with a lot of the clinical findings in this patient. We also notice that up here, there's some electron-dense deposits that are present within the mesangial region. And so these electron-dense deposits are the immune deposits that we detected by immunofluorescence microscopy. Moving on, we see other areas where there's some more substantial changes within the capillary loops. And so here we have actually some widening of the subendothelial regions and some widening of the mesangial regions. And this is an indication that there's probably been some endothelial injury, and this could be due to a number of factors. In this instance, it could be due to the IgA nephropathy and some of the immune complex deposition process. And here we see some of that remodeling that's existed for a while, because we see some more matrix in this area that's subendothelial and expanding from the lamina densa, and we also see cell processes in these areas as well. And we'll look at a higher power here because we see some more abnormalities within the basement membrane. And this is a higher magnification view of that region. And so we see that the lamina densa becomes extraordinarily thin, and there's a lot of irregularities here. So here's some remodeling and potential damage or evolving damage to the glomerular basement membrane. And this is probably one of the processes that leads to some of the segmental necrosis and segmental scarring and injury that we do see in IgA nephropathy. How this happens, I think, is still a bit of a mystery. And then here's then a good area of mesangium. We can see that it's expanded. There's a lot of stuff that has cell debris-like qualities. And then there's some of these electron-dense deposits that are frequently underlying the glomerular basement membrane. And these are the IgA immune deposits that are present here. And then this is just an electron microscopic view of a foam cell that's present. We can see that the nucleus is eccentric and it's being pushed to the side by all the lipid that's retained within the foam cell, and there's some atrophic tubules. So I'll move on to our final diagnosis, and it's probably not a surprise to anyone. It's IgA nephropathy with the additional features of focal segmental and focal global glomerulosclerosis, and then there's a mild degree of fibrosis and tubular atrophy in addition to that. We went through the histology and came up with a score for the Oxford classification. And I showed you that we did have mesangial hypercellularity. So this was present in the majority of the glomeruli. And then we did also have segmental glomerulosclerosis. So it's an M1 and S1, but we didn't have these other features of endocapillary hypercellularity. We didn't have significant tubular atrophy and interstitial fibrosis, and we didn't have any cellular crescents either. So what can we say about IgA nephropathy and inflammatory bowel disease? Well, there's been a couple of studies that have really shown that there is a strong link between IgA nephropathy and inflammatory bowel disease. One is by Arcana Labs, another one is from Nanjing, China. And both of these looked at patients that were biopsied that had diagnosis of IBD. In the Arcana Lab study, they showed that 24% of the biopsies of patients with clinical histories of IBD had IgA nephropathy. And this was higher than the overall frequency of IgA nephropathy in all of their cases, which was 8%. Interstitial nephritis was another common finding in IBD patients, as well as arterial nephrosclerosis and acute tubular injury and proliferative glomerulonephritis. But IgA nephropathy is the #1 association. In China, it was even more significant. So like 67% of their biopsies in patients with IBD showed IgA nephropathy. And then these are the other diagnoses that they found. So there is a strong association. There's also a Swedish study that showed, looked at almost 4,000 patients and almost 20,000 controls. They found that of the IgA nephropathy patients, there were about 5% that developed IBD, whereas only 1.65% of the controls. So there was you were more likely to develop IBD if you had a diagnosis of IgA nephropathy. Similarly, if you had a diagnosis of IBD, you were more likely to develop IgA nephropathy. So of those patients that had diagnosis of IBD, 2.5% developed IgA nephropathy compared to 1% of the controls. And in addition, IBD is associated with increased risk of end-stage kidney disease. So there could be a connection. Maybe there's some connection. The one thing in common and that's intriguing is that there's mucosal immunity and dysregulation of mucosal immunity, and dysbiosis is thought to be the underlying mechanism for IBD. And this also may be a mechanism that leads to the production of IgA and IgA nephropathy that leads to the deposition of IgA within the kidneys and causing the kidney disease. To help support that there may be common etiologies in these what would be thought to be somewhat disparate diseases, is there is some shared susceptibility genes that are involved in regulating pattern recognition receptors for innate immunity, as well as complement. So that's all I had. Is there any questions or comments for this case?
I think Ram answered my question. So for CD68 staining, do we have to let you guys know ahead of time, or can it be added to the slides?
CD68 staining?
Yeah.
What do you want to do CD68 staining for?
I mean, for the question often is in IgA is to whether to immunosuppress or not, and at least based on biopsy, the ones that are more likely to respond to immunosuppression are E1, C1, necrosis, and maybe M1. And the sclerotic lesions do not respond to immunosuppression, but there's been talk in the IgA world that the more there is macrophages in the glomeruli, they're more likely to be responsive to immunosuppression more than the CMS scoring and the clinical scoring in terms of proteinuria. So maybe this would add to the entire, it'll be one extra piece of the puzzle when we decide whether to immunosuppress or not.
Yeah, I mean, I think that's something that we haven't routinely done. I think that's something that we should discuss and see whether that's a test that's that we should add. If that's something that you're going to use to determine whether or not to immunosuppress patients, then that's something that we can do.
Yeah.
Yeah, thanks for bringing that up, Amal. We can take a look at it. That paper does show they develop what they call an I-score for infiltration by macrophages using that CD68 stain. So we can certainly take a look at it and see if that would be useful, how to incorporate it into our practice. Thank you.
Okay, should we move on to the second case? Sure. The clinical history is going to be presented by Amruta. I didn't have any slides. I don't know if you have slides. Or...
Yes, I have slides I can show. Okay. Good morning. So I'm just going to go over this case in chronological order because I think that might make the most sense for this patient. So basically, this was a 55-year-old female with a history of asthma, bronchiectasis, and chronic sinusitis. She was first seen in the ED 2 weeks prior to the hospital admission that we were consulted on. And she came in with constant joint pain and bilateral foot swelling. Coincidentally, turned out to be positive for COVID at the time. There was a leukocytosis with a WBC count of 13,000, and she had eosinophilia. She was subsequently discharged from the ED with symptomatic treatment and closed outpatient follow-up, specifically with rheumatology because of her joint symptoms and foot swelling. So she returned 2 weeks later to the ER with progressive worsening of her joint pain, as well as paresthesia, bilateral leg itching, and bilateral leg rash. She also complained of increased wheezing, using her albuterol inhaler more frequently. There was a worsening leukocytosis during this admission, an increase in eosinophilia. This was all noticed in the rheumatology clinic on the day when she was sent to the ED, and rheumatology was very concerned and sent her to the ED for hospital admission. Our service was involved because she had a rise in creatinine from 0.76 in October of 2021 to 1.2 with hematuria and proteinuria. In addition to all the history that I've said, the only additional history that we got was that she had used some over-the-counter NSAIDs for the neuropathic pain that she had. So in terms of her vitals, what was significant was her blood pressure was 162/81. All other vitals were stable. On her physical exam, we saw bilateral conjunctival injection. There was nasal congestion, which was affecting the quality of her voice. There were boggy nasal turbinates. On her respiratory examination, there were faint expiratory wheezes. And this was the skin findings that we found. It was on both her shins and her feet. They were warm, dry, few non-blanching, dark red or purple petechiae and purpura. On her neurological examination, there was a sensation was intact, but there was some reduction in her power on her lower extremities that we attributed to pain. So in terms of her labs, we had a CBC count that was significant for a WBC count of 21,900 with 50% eosinophilia. Her creatinine is currently 1.2, and her baseline seemed to be about 0.7 to 0.8. Just a disclaimer is that we didn't have very frequent labs on her prior to between the hospital admission and 2021 in October. So it is possible that this was a more gradual rise in creatinine than we saw. Her urinalysis was significant for 1+ protein, 3+ blood, 3 to 5 RBCs, bacteria, and squamous epithelial cells. Urine protein creatinine ratio was 1.4. Her urine sediment under microscopy, we saw the dipstick was 2+ blood, trace protein, specific gravity was 10. There were few RBCs, none looked evidently dysmorphic. And some WBCs, we suspected this could be eosinophils. We did not have access to urine eosinophil staining, so we weren't able to confirm this. And there were no casts noted. And this was actually the slide of her from her urine microscopy that we did. So additional labs, we had Hep B and C, which were negative. HIV was negative. ANCA panel, the titer was 1:512. MPO was positive, PR negative. C3 was normal. There was a mild elevation in C4. IgE was 829. CRP 6. A renal ultrasound showed echogenic kidneys at 11 centimeters and 12 centimeters, and we decided to go ahead and proceed with biopsy.
Okay, any questions? Okay. Any differentials people going to throw in there?
I have a question. Did you have a skin biopsy at any stage?
Yes, we did have a skin biopsy, and the biopsy finding was significant for neutrophilic infiltration, which in the right clinical context could point to EGPA.
Okay. So I'll go on to the biopsy, and I'm just showing you a medium power magnification of a portion of the biopsy, and this essentially is what the entire biopsy looked like. So it was abnormal throughout. We see there's a number of glomeruli that are involved by crescents, and I'll show you these at higher magnification. Many of them are cellular, but also there's some with some fibrous components in those crescents. In addition, the interstitium is infiltrated by numerous inflammatory cells, and we'll look at those at higher power as well. The tubules show some attenuation of the epithelium, so they're not looking too healthy at all either. Here's a higher magnification view of one of the glomeruli. And we see that this portion of the capillary, this portion of the glomerular tuft has capillary loops that look relatively normal with no obvious abnormalities. We can see these nice thin ribbons of glomerular basement membrane, really thin inapparent mesangial regions. This is the vascular pole. But over on this half, there's a lot of problems. So we see that there's areas, there's a few eosinophils in here too, but there's some eosinophilic material that is consistent with fibrin present. We see areas where the capillary loops appear to disappear and fibrin appears present in the urinary space. And then we see this prominent cellular reaction present in Bowman space. And this is a cellular crescent here, and this is segmental necrosis here. Here's another glomerulus where we're seeing more fibrin and destruction of the capillary walls present within a segment of the glomerular tuft. There's not as prominent of a cellular reaction in this instance, so it's mostly a region of segmental necrosis. And then we see this adjacent capillary loop shows no really obvious abnormalities. So we don't see leukocyte infiltration, but we see an adjacent area of segmental necrosis. Here's a PAS stain that just highlights the fibrin, the staining that is present in this portion of the glomerular tuft and obscuring the underlying architecture. in an area of segmental necrosis. And then this is an older lesion. So many of the lesions were cellular crescents and segmental necrosis, very active, but there were also some lesions that showed some evidence of chronicity. So this is an area that now has undergone remodeling and the accumulation of abundant matrix and even attachments to Bowman's capsule. So this is a portion of the glomerular tuft that's now been replaced by scar tissue. And so this is segmental sclerosis or segmental scarring. And then here is another glomerulus where we see some of the cellular crescent like regions in the periphery, but there's also abundant areas of sclerosis that's entrapping and engulfing much of the glomerular tuft here. And so this is like a fibrocellular crescent. And so this is a glomerulus that has been attacked and has the inflammatory process is probably on the resolving end of things, and most of the damage has already been done. We can see in the interstitium, which we'll look at in a few slides, is also filled with abundant inflammatory cells, notably numerous plasma cells, as well as eosinophils. And then here's a glomerulus. There were a few glomeruli that didn't really show any lesions whatsoever, but over 60% of the glomeruli in the sample were involved by crescents or segmental necrosis or both. When we look at the uninvolved glomeruli, there's really no obvious abnormalities. There's a couple of eosinophils present in the capillary loops, which we don't typically see, but this is a unique case. And then there's also abundant inflammatory cells, including eosinophils in the adjacent interstitium. When we look away from the glomeruli, we can see that there is a robust interstitial nephritis. So there's lots of interstitial inflammatory cells, as I mentioned, eosinophils, plasma cells, lymphocytes, and some histiocytes as well. And they're not only in the interstitium, but they're invading the tubules. So we have a tubulitis as well. So this is an active interstitial nephritis that's also causing damage to the kidney. And then here's a higher magnification view. Here's a plasma cell. We can see this, what is termed a clock face nucleus. And then we see this area, this light area adjacent to the nucleus, which is the nuclear huff or the garden, where the Golgi apparatus is found within the plasma cell. And then here are the abundant eosinophils, and I think I have an H&E stain that helps highlight eosinophils that really show their bright red granules. And at higher magnification, we can see the bilobe nucleus and then the bright red eosinophilic granules present in all of these eosinophils. By immunofluorescence, the only thing that we really saw was fibrin staining in several glomeruli, consistent with the necrosis that we saw by histology, but no immune deposits. So the findings are consistent with a posse-immune complex mediated glomerulonephritis. And then by electron microscopy, the uninvolved capillary loops looked relatively normal. So here we see good intact podocyte foot processes. We see endothelium with intact fenestrations. We see a normal appearing lamina densa with a lamina rara externa and interna. We see mesangial regions that don't show obvious abnormalities either. And then in areas that are involved by crescents, we can see collapse of these capillary loops, loss of endothelium, and prominence of the epithelial cells in the urinary space that overlie this area of the glomerular tuft that's undergoing destruction. So the final diagnosis, diffuse segmentally necrotizing and crescentic glomerulonephritis. It's posse-immune complex mediated, it's PACA positive, and the findings are consistent with the diagnosis of EGPA. And we also have an eosinophilic interstitial nephritis. So renal involvement with granulomatosis with polyangiitis. ANCA positivity is present in about 40% of the cases, and it's usually anti-MPO, as in this case. Clinical manifestations in EGPA, asthma is almost always present. There's frequent cardiac involvement, and there's also usually ENT and neurological manifestations. So definitely some of the findings this patient had, but not all. Renal disease is only present in a minority of the cases. So it reported to be seen in about 25 to 30% of the cases. When it's present and biopsied, plus immune complex mediated glomerulonephritis, as we've seen in this case, is what is found. So that's present in about 80% of the cases. And then 10% have been reported to have membranous nephropathy, 3% membranoproliferative. These are mostly in the ANCA negative groups. And then a pure interstitial nephritis is also seen. And then many of the patients also have a significant interstitial inflammation, as we saw in this case as well. So treatment, I think the treatment for ANCA associated vasculitis is similar for EGPA as for the others. The only thing I noted was that there is a relatively recent study that was looking at also adding anti-IL-5, suggesting that this might lead to longer lasting remission and maybe allow people to use less glucocorticoids. So that's all I have. I wonder if we have any follow-up, and if you'd let us know what you did, Amruta, as well as answer any questions that people might have.
Yeah, absolutely. So when we got the diagnosis, we actually had the patient admitted, and we gave high dose steroids, so 1 mg per kg for 3 days IV, and we gave 1 dose of rituximab. The plan was to have another rituximab infusion in 2 weeks, but we're having a lot of troubles with financial assistance with that. But when I saw her in clinic after she had the rituximab and the high dose steroids, she was also discharged on steroids at 80 milligrams, oral steroids when she went home. When I saw her in the clinic, she was doing significantly better in terms of her paresthesias, which was what was one of her main complaints. We're still, the only thing we're able to monitor at this time in terms of her kidney function, because her creatinine actually normalized to 0.9 when she came into the hospital for this treatment. So we couldn't look at the creatinine to see how she was responding to therapy. So we've been following her hematuria to see how she's been responding.
Yeah, I mean, I think one of the extraordinary parts of this case is the biopsy looks awful. I mean, it looks like she should have much more significant renal failure than what she's expressing clinically. And I'm not sure if I have a good explanation for that. I don't know if anyone else does. Okay, any other questions, or should we move on to the third case? I think Behzad, you're up.
Yeah, so if there are no other questions, let me start. My apology in the beginning, it looked like my mic was closed, so thanks, Kelly, for starting the session. Can anybody see the screen?
You should switch displays as you were about to do there.
Is it good now?
That's perfect.
Okay, all right. So Dr. Malik will present the clinical of this case.
All right, so time's short, so I'm going to fly through these. This is a 47-year-old man who first came into contact with UW Medicine and renal service when he was hospitalized recently on the 1st of July. His main presentation had been recurrent syncopal episodes, which had been going on for about a couple of years before this. He thinks it was mostly posture related, happens almost 10 to 12 times a day, very fleeting, lasts for a few seconds, and considerable dizziness and lightheadedness. And a few times that his blood pressure had been monitored, had been extremely low during these episodes where systolics sometimes drop into the 40s and 50s. Quickly, his background, past history did have hepatitis C virus, which was treated with whatever this Mevrit thing is for about a year ago. And part of his report, he'd been in sustained viral remission since. He has a long history of smoking. He's cut down from 1 to half pack per day, but about 30 years history of smoking. Previously heavy alcohol use. He quit a couple of years ago when he started having these syncopal episodes, but does admit to smoking meth almost pretty regularly because he thinks that gives him energy and stamina to keep going and keep working. Previous history of cocaine and marijuana use as well as some injected cocaine in the past. Used to work as a roofer, and thankfully is not working as a roofer now with all these symptoms. And review of system quickly, mostly constitutional symptoms, fatigue, weakness, weight loss, alternating constipation and diarrhea. Okay, so he was initially evaluated at St. Joe's, and they did the usual cardiac evaluations with an echo, which showed preserved EF, but some ventricular thickening, and they did find some peak systolic longitudinal strain to be severely reduced. And he also had some runs of VT and third-degree heart block while he was there. They also went ahead and did a cardiac MR where there was, I don't think it was completely very characteristic, but still showed subendocardial prominent late gadolinium enhancement. Next.
Yeah.
So additional evaluations that those guys did there, of course, included a monoclonal workup where he showed a lambda skew with light chains of 7.64 with a suppressed ratio of 0.26, and did have an IgG lambda M spike of 0.3 grams. His initial spot urine protein electrophoresis immunofixation weren't that great, but they repeated a 24-hour urine, and that did show about 5.5 grams of protein, which was predominantly albumin with just a speck of M protein, and with immunofixation, again, confirming that it's a faint lambda light chain, Benz-Jones protein and IgG lambda. Creatinine remained stable, so did the hematologic panel. Serum albumin was 2.1. They did a fat pad biopsy, which was negative for amyloid, and a bone marrow biopsy showed lambda restricted 15% plasma cells. Quickly, he was discharged with midodrine, kept on having issues, got readmitted. After he had another syncopal episode, he was transferred to UW on 7/1. Here, the cards did some usual workup where BNP and troponin I were normal. They went ahead, and I do not know why they didn't get it, but they wanted an outpatient troponin T and an NT-proBNP. So I don't think that has been done so far that I will check. They increased his midodrine, started fluorocortisone on him, and sent him out. The repeat serologic workup was pretty similar to what we saw at St. Joe's. And then hematology was consulted while he was there. And they said, well, this looks like MGUS, but we need a tissue diagnosis to see if we need to treat him.
Okay, any questions or differentials? For the sake of time, please type your questions or differentials. I will have a look at the chat box. If not, let's start quickly. And in the meantime, you can keep filling in the chat box. Let's see. So this is the biopsy, the low magnification. It was a very good sample. We had 29 glomeruli starting from the renal capsule and also a portion of the medulla. As you can see, this is the trichrome stain, which we use for chronicity, and showed very focal chronic injury in some areas, including also some in the subcapsular region. And about 3 to 6% of the glomeruli were globally sclerosed. So most of them were patent. And this is how the glomeruli on the left, this is how the glomeruli look like in this biopsy. Now, this is how a normal glomerulus looks like. This is from another biopsy. So if any of the fellows wants to tell or type in the chat box that what is the prominent abnormality that you see in this glomeruli, that will be great. I will start describing them in the meantime. So when you compare the mesangial regions, you see that there is mesangial expansion. In some areas, it also looks a little bit nodular. The mesangial areas are hypocellular or rather acellular, and a little bit of PS positivity as well. We don't see mesangial hypercellularity similar to the IgA case that Kelly showed, definitely. And this is how the glomeruli look like on different stains with periodic acid shift. We already looked at Jones methylamine silver, that also is good for extracellular matrix and basal membranes, shows kind of Jones weak, not super weak, but kind of Jones weak deposits in the mesangial regions, as well as in the peripheral capillary walls that we will have a closer look. By H&E stain, we see that the deposits are hypocellular, acellular, pinkish, amorphous, and they stain blue with Masson trichrome. So the highlight was mesangial expansion by amorphous acellular material. when we look at the Jones methylamine silver, we see that also in some of the peripheral capillary walls, we have kind of very peculiar abnormality in the glomerular basement membranes, where we see these long hairy spikes that resemble eyelashes in multiple capillary loop. These can be identified. So this is another glomerulus, similarly mesangial expansion, relatively Jones-Wick material, hypocellular. And then this part is basically a zoom in from this region. And you can very beautifully see these long hairy spikes that resemble eyelashes. Okay, so only a few glomeruli were globally sclerosed. Some of them were like these, completely collapsed capillary tuft, like the typical appearance of the globally sclerosed glomeruli. And we had one glomerulus that also, though, was completely obliterated, but it seemed like it is obliterated by deposition of the same material that we saw in the patent glomeruli. So that's telling me that the process has been going on for some time and it's not very acute. Looking at the tubular interstitium, in most regions, tubules, they looked fine. Tubular atrophy was pretty focal and the tubules were back-to-back. But in areas with focal interstitial fibrosis and interstitial expansion, what we can see that similar like Jones weak material that we see in the glomeruli looks like it's depositing in the interstitium. The vessels by light microscopy, they look fine. This is an interlobular artery. And as you can see, all layers are beautifully visible with no apparent abnormality, vasculitis, or deposition process. Okay, so I hope that with that light microscopy, you have developed a good differential, and I can see that people are calling like AL amyloidosis as a possibility. So let's see if immunofluorescence is confirming that or not. Here are the only 3 positive immunoreactants for IgG. There was kind of like smudgy staining in the mesangial regions as well as segmental in the peripheral capillary walls. IgA, IgM, C3, C1q, fibrinogen, albumin were all negative. Kappa was completely negative. Lambda was positive in the glomeruli and also focally in the tubular basement membranes and interstitium. Lambda was stronger than IgG, although IgG could not basically remain unnoticed, certainly in this case, but it was weaker. Again, when we look at the vessels or vasa recta, we see this kind of similar pattern. In vasa recta, the IgG staining was even more subtle, and lambda staining was jumping out and was stronger, and kappa was completely negative as well as the other one. Okay, the other immunoreactants. Looking at the electron microscopy, we have a couple of capillary loops here, and this is the mesangial region that we're looking at, and you see that there are not many cells. So the same correlates with the light microscopy findings, has kind of a hazy, cloudy appearance. Let's look closer. This is a closer view of the same region that gives us an impression that there are some tiny fibrils there. At a higher magnification, you can see that there are numerous fibrils that are haphazardly arranged and organized in basically any direction that you can imagine. So obviously in this context, it is important when we're dealing with fibrillary deposits to see what size those deposits are, and that will help us for the differential diagnosis. In this case, the multiple measurements that we did came up with an average diameter about 10 nanometer. Okay, so with that 10 nanometer, basically that the measurements of the fibrils fall within the spectrum of amyloidosis, which is 8 to 12, and falls a little bit below the threshold for fibrillar glomerulonephritis, although we have other tests for confirmation as well. So for amyloid, it's usually 16 to 24 nanometer. That's what we consider. So in some other regions as well, we see this irregular thickening of the glomerular basement membrane with this peculiar appearance. As you can see, kind of resembles basically roosters' comb, and that's the way that they are named as well. This is a podocytes on top that shows extensive food process effacement. And as you can see that this appearance exactly correlates with those long hairy spikes that we observed on Jones methylamine silver. And again, in these areas, the fibrils haphazardly arranged with an average diameter around 10 nanometers. So everything fits with what we saw in the other parts of this biopsy by electron microscopy. Looking at the podocytes, there is very prominent podocyte injury with extensive effacement of food processes, and also with these old little microvillus processes that we call microvillus transformation that also Kelly showed in his case, indicative of significant podocyte injury. The deposits were not limited to glomeruli, and also we could see them in the tubular basement membrane. So these are 3 proximal tubules, and 1 peritubular capillary in the tubular basement membranes, as well as interstitium. We had similar deposits to those that we observed inside the glomeruli. So obviously, as also in the chat box, people have been listing, amyloidosis is the number 1 thing that we think about. And for confirmation of that, we do Congo red staining, and we polarize that with polarized light. So that showed a significant deposition of Congo red positive material with apple green birefringence in the glomeruli, as well as in the tubular basement membrane and in the interstitium, as well as in the vessels. Okay, so now we know that we're dealing with amyloidosis. We know that there was very significant staining for lambda light chain and no kappa light chain. Therefore, the diagnosis is primarily AL amyloidosis involving glomeruli, tubular basement membrane, and so on and so forth, with very mild chronicity. We had that twist in this case that observed that IgG staining as well. So obviously, one of the questions is that, are we dealing with AL or light chain amyloidosis, or this is a case of combined heavy and light chain amyloidosis, AH and AL? So for that reason, we did 2 confirmatory studies. Number 1, we did mass spec, which is a more sensitive assay for the subtyping of the amyloid. And the amyloid, the light chain, the mass spectrometry confirmed presence of lambda light chain in the Congo red positive deposits, and did not show any signal or significant spectra for IgG. We also performed IgG subtyping, and IgG subtyping, interestingly, showed that there is a restriction for IgG1 and the deposits. Okay, so how are we going to basically put these findings together? So for IgG subtyping, the interpretation, as you know, by immunofluorescence, what we can say is that if the deposits are monotypic or not. We cannot establish monoclonality, obviously, by these tests. So we observed monotypic IgG1. This finding raises concern for a primary light and heavy chain amyloidosis. However, this basically concern was not confirmed by the results of mass spectrometry and the deposits. Okay, so here, basically, I would like to stress on what I mentioned earlier, that we need to consider that the finding of monotypic immunoglobulin staining in the biopsies does not confirm or establish monoclonality. And sometimes other kind of tests, although I mean that the test that I'm going to mention also not establishes monoclonality per se. However, it is one step forward, and it is certainly more specific to detect real monoclonal or monotypic deposition of immunoglobulins in the biopsy. And what I'm talking about is using of heavy chain, light chain, basically immunofluorescence microscopy, antibodies for heavy chain, light chain that target these regions of the immunoglobulins close to the hinge region that can detect basically both light and heavy chain. And in this study that was done at Mayo Clinic, they were able to exclude some of the cases that initially by simple immunofluorescence studies were thought to be monoclonal immunoglobulin deposition, such as in some cases of fibrillar glomerulonephritis or some cases of IgA nephropathy, and they confirmed that indeed the deposits were polytypic and they were not monotypic. In this particular case, we would expect that if we have a heavy chain light chain amyloidosis, or if we have a light chain amyloidosis, basically we wouldn't be seeing any staining, because we do not expect to see basically the intact immunoglobulin. We're talking about the free light chains or the free heavy chains. So that, yes, I mean, that could potentially help if we're interested to do one further confirmation if this is a case of AHAL or just it's a case of AL. So the largest case series that have been published for heavy chain and heavy light chain amyloidosis is this case series from Mayo Clinic that they studied 16 patients of combined both heavy chain or heavy and light chain amyloidosis. And what they found in comparison with the primary light chain was that these cases had less frequent concurrent cardiac involvement, had higher likelihood of having circulating complete monoclonal immunoglobulins, lower sensitivity of fat pad biopsy for finding amyloidosis, and also bone marrow biopsy for detecting amyloid. They had higher incidence of hematuria, and overall they had better patient survival, which was probably related to basically lower cardiac involvement in these cases. But that's all. So overall, putting it together, is it a case of heavy and light chain amyloidosis? I have to say that overall, per our current definitions for heavy and light chain amyloidosis, we would like to see both heavy chain and light chain to be strong, equal intensity, and also, I mean, confirmed by mass spectrometry. So with this particular case, I think we cannot rule out a component of heavy chain in the deposits. However, per our current definitions and understanding, it's likely light chain amyloidosis. So with that, and my apology that I went over time because we started late, I would like to take questions and have further discussions.
And maybe for anyone who needs to go, totally understand. Dr. Najafian, just to start, there's a question from Dr. Shannon in the chat.
Okay. Is there a physical chemistry explanation for why lambda is more common than kappa in AL? I don't know. I'm not aware of that. If anybody else.
I think some of the lambda light chains, which are amyloidogenic, have a distinct interaction with the resident mesangial cells and converting them into a phagocytic phenotype. And that phagocytosis leads to classic SNPs breaks in the lambda light chains, making them more sticky and causing them to stick together to make beta-plated sheets. So the exact mechanism, I'm sorry, I'm not recalling right now, but it is related to the specific interaction between lambda light chains and the resident mesangial cells.
Thank you.
Zahn, so
yes.
I may have had just my head in the sand, but when did we start doing our own mass spec?
Oh, it's already started. So this was indeed our own mass spec.
Yeah, and that just started?
Well, it has started a few months.
January.
Yeah, January.
That's great. Thank you.
Thanks to Kelly and our other colleagues in the in lab medicine, Andy Hoofnagel and others.
Well, I'm going to close us out. Thanks for everyone for some excellent speakers. Quick announcements, just to reinforce Danielle's email, the State of the Division presentation's been rescheduled for September 30th by Zoom, thanks to the division speakers who are willing to reschedule their talks. And also a quick plug for next week. We have an invited speaker, Dr. Bhargava from the Department of Radiology. He's a well-recognized speaker in education and workplace psychology. I think it'll be an interesting talk. He's going to tell us about personal finance for medical professionals. The 30-minute time frame is shorter than he typically uses. So he's going to send out, or we're going to send out some material that he's offering us as a kind of preparation for anyone who wants to lay a foundation for his talk. So that should be coming out in an email for anyone interested. And with that, thanks again for everyone coming to our first nephrology grand rounds of the year. Look forward to seeing you next week. Bye now.
Thank you.